Hey, it is Friday. Thank goodness. Happy Friday to you. I am Julie Hirschberg, the owner of Reactive Physical Therapy and Wellness, coming in to our Facebook page every Friday to chat a little bit about what we're doing, what we're learning at Reactive, how we're responding to the ever-changing environment, all of that. And if you haven't heard of Reactive Physical Therapy and Wellness is a neurologic practice in the Los Angeles area where we focus our time and our passion for working with people with neurologic disorders. And it's why we jump on every Friday to talk about what we're learning and what we're doing. And in particularly, we have a fellowship program called the Schmidt Movement Disorders Fellowship, where we train physical therapists in movement disorders. And about once a month or every 6 weeks, we do a mini course where we dive in deeply to different topics. And one of those topics we're going to talk about today, which is camptocormia and low back pain in dystonia. But let me just get you up to speed about where we are at Reactive right now. So it's been a couple of months since the COVID-19 hit, and right now we are doing a lot of telehealth. It's now covered by Medicare, so we're spending many hours. Many of us are actually feeling a little screen fatigue. I've been spending a lot more time outdoors to try to counter some of that. And in fact, I just got off a co-treat with our fellow. We did a telehealth co-treat. It's actually one of the nicest parts about this is that we can come together this way and we could work with somebody at his house and got him crawling on the grass and doing some cool postural exercises on the side of the grass. And it was really fun, to be honest. I really loved it. And frankly, I also think we were working on some things to prevent camptocormia. So as I mentioned, we have our mini course coming up. It is next week, actually, on Thursday. We also are opening our practice very gradually, but we're opening next week. We're going to have one therapist a day, one patient per hour for that time. And we'll host our course online as we've been doing actually for the last couple of years anyway. And I'm excited for this year. We've done this course a couple of times. Every year there are a lot of new pieces of research and applications. And this year we've tweaked it a bit. Brittany, Kim, and I are working on it together. And this is so we can talk about how we can tease out what's low back pain and what's camptocormia, what's both. So I love working with Brittany, and I love bringing this kind of neuro-ortho mindset to this. So that's the course for next Thursday. But today we're going to talk about one aspect about this, and that is with camptocormia and some of the other postural problems. Is it dystonia? And how would we know? How would we look at that? How might we even treat it? So let's dive right in. So first, and just very briefly, what is camptocormia? So the definition of camptocormia is that it's diagnosed when there is trunk lean, trunk flexion greater than 45 degrees, but it reverses. So if you have support, like on a walker or in sitting or supine. And sometimes we don't only see camptocormia, we will see PISA syndrome. And PISA is a lateral flexion greater than 10 degrees. And you can imagine like the Leaning Tower of Pisa. But this also reverses. So it's not a fixed deformity, it's not scoliosis. And we often see both of these things together in Parkinson's disease. So this can be really challenging to treat. It can be a big problem for people who have it. So this is why we're talking about it, because we want to really be able to help people who have this syndrome. So there are actually a lot of potential mechanisms behind camptocormia. Things like medication changes. They've found that some people actually have a myopathy, spinal cord disease. Maybe they do have scoliosis. Maybe it's even dysautonomia. So that one was really interesting to me. Like you have an orthostatic hypotension, so you're bringing your body forward to get more blood to your brain. But one of the things is it could actually be dystonia. I have definitely seen this. And how would we know, right? So how would we know? And often it's not just one of those things, right? It's not just dystonia, it's usually the multifactorial. So the first piece when we look at dystonia is we want to see if it responds to a sensory cue. So for example, one of my favorite people of all time that I have worked with, she had a little cue here at her ribs, and then that would change her whole posture. And it wasn't enough physical push to change it, it was just a light touch. So that would be a kind of sensory cue that would change her posture. We might also look to see if there's overactivity of muscle groups. So using surface EMG or palpation, this is harder to do in the telehealth setting for sure. Or is it underactivity of other groups? And that might show us that there's some sort of myopathy or something like that. And then finally, if we are seeing that some of the postural writing responses are impaired, this is something that we see in cervical dystonia. That might also lead us to think that the postural syndrome may be part of a dystonia in general. Finally, some people actually will have Botox treatment, and they may Botox one side that appears to be overactive, and then they have a positive response. And there's some pieces of literature to show and support that. I've seen that less clinically, but it is there in the literature. So those are 4 ways that we may know that it's dystonia. And I want to talk a little bit then and go into more detail about the third way, the proprioceptive or sensory, maybe even vestibular. And I am so excited for this because I thought it was really brilliant. Brittany Kim recorded a video of how to do this. We shared it on Instagram, but I'll plop a link here in the comments because I thought it was really great. One of the things that we think about possibly contributing to that dystonia is an impaired subjective visual vertical. So, or SVV for short. So I have my hands like this because I want to demo this for you. If somebody is thinking that this is the middle, and therefore they have a lean in that direction, and their perception is that that is the middle, it's going to be really hard. They'll actually feel like they're falling over when they're more upright. So the subjective visual vertical, which is measured with a bucket test, love it, it's just a bucket. And it was originally designed for vestibular, but I've definitely found it very clinically useful for postural problems. So typically you would have a bucket, so you do this in person, you'd have a bucket, they're looking into it, and it's got a line. And then on the outside of the bucket, I was using my iPhone stuck to the bottom of the bucket. You would twist it one direction so that line is off center, and then slowly bring it back, asking them to tell you when the line is back to vertical. And if the line is indeed not vertical, you can measure the degrees that it's off and see that their subjective visual vertical might be skewed. And I've seen this impacting people with postural problems. Pisa syndrome, Camptocormia, usually the combined version of those two, and that can be an underlying component of dystonia. Now, Brittany recorded this great video because she did this in telehealth simply by sharing her screen. Now, it's not the same as the bucket test by any means, but she shared her screen with a circle and a line. And what's cool in like Google Docs or Google Slides, as you turn the circle, you can see degrees on it. So you can have the patient up close to the screen and ask you to ask them to tell you when it's vertical. So I'll share that video with you. I think it's really helpful if this is something that you want to screen in telehealth. And then what's nice is you can go right into treating that as well. So so that's one piece of how would you know that it might be dystonia. So that's kind of the proprioception, spatial body awareness piece that might lead to muscle overactivity. It's one of the potential pathophysiologies of dystonia, and especially in Camptocormia. So I want to just review those quickly again. We talked about a sensory cue being a clue that it's a dystonia leading to Camptocormia, a very light sensory cue, using palpation and surface EMG to look at muscle overactivity and potentially muscle underactivity as well. The third, the sensory piece, the proprioceptive piece that we talked about with the subjective visual vertical. You could also simply look at things with eyes closed and kinesthesia to give you an idea about that. And then the fourth thing is that response to Botox. And I'm very curious if anybody else has seen a positive response. It is there in the literature. I haven't seen a really positive response myself clinically. So I would love to hear if you have seen that. So in summary, Camptocormia, Pisa syndrome, they can be dystonia, absolutely. And how we know is through those 4 ways that we could kind of tease that apart. And I think working together with a movement disorder specialist is really important for that. But that still is only one little piece of the puzzle. So they might have components of dystonia. They might have components of low back pain contributing to this. They might have some impaired balance. They might have orthostatic hypotension, and all of those could be contributing to the postural problems. So that's why we have a whole course on it. It's taking place next week. I hope you'll join us for that. But in the meantime, reach out to us with questions. I'd love to hear about your cases, what has been hard with these cases, especially in telehealth. I'll share with you some links here in the comments. I have a couple of full text articles talking about dystonia as a potential mechanism in Camptocormia, and Brittany's great YouTube article as well. So I hope to see you next week. I'll be back here on Friday for a little recap from our course, and I hope you have a very relaxing, rejuvenating weekend, and stay healthy.